Happy Wednesday. For some of you, it's 5. For some of you, it's 6. Some of you, it's later. I don't know if we have international people on. But I'd like to thank everybody for joining us. I've looked through the names and I see there's Brian, Richard, and a lot of people that I know and some new faces on there. I thought tonight, these are all recorded, and I always try to do things a little differently for each webinar, just to kind of keep it interesting and keeping people coming back. So I would say to the NuSmile team, if you see a question that is apropos and you think it's something that we should answer, then just interrupt me. Go for it. The other thing I did tonight is I set up a overhead camera with a sew-in and a model, and bring in the pedal and the pedal. Good. And so that way, if someone has questions about something and they want to see positioning, something like that, we can do that tonight. Okay. So we've got about an hour to go through clinical slides and through all the slide deck, and then we're going to answer questions. So away we go. This webinar is really a two-parter, right? And some of you may have seen the mastering before. Some of you, this may be completely new, but we really consider this a number 1 and number 2. So the introductory webinar, and you see my good friend, Dr. Ann Bynum there, and Ann and some of the other NuSmile KOLs have the intro recorded, and it's also about once a month. And in that intro webinar, it really goes into just the basics of how to use these devices. What's the difference between a traditional injection and intraosseous anesthesia? What are the general guidelines on how we give an injection? How does the fluid pass from soft tissue, into the level of the nerve? Tonight, we're going to get into more details. So some of you, and we're going to do a poll here in a minute, and that's always helpful to me to really massage the information and make sure everybody gets what they need tonight. But we're going to find out how many of you are new and how many of you actually have these devices. But tonight's really should be the mastering. So what we try to do at each one of these webinars is we have a base set of information to go over. And then as questions coming through the month, Aaron and Jordan and Chris and everybody else in the NuSmile team, and all of you that post questions online or you email me or text me directly, we try to get to some of those questions as we work tonight. So as I said, there is, and more as we do these webinars, there's a great pile of information. And besides the intraosseous anesthesia, I'd also want to point out Casey Lynn's webinar, multiple webinars on scanning. Scanning is something I think that it's its infancy in pediatric dentistry. NuSmile has a phenomenal scanner, and not only is their scanner phenomenal, but the service and all the help from them and pricing is absolutely phenomenal. So for those of you that are introducing, they're new to scanning or thinking about it, I really encourage you to watch either one of these recorded webinars or the next one that Casey does. So just a little bit about me. As I said, I know some of you, probably about half of you or maybe a third of you that are on there. And so my name is Josh Solomon. I'm, of course, a pediatric dentist. I had things easy. I'm a second-generation pediatric dentist, so all of you that started from startups, my heart goes out to you because I was a little spoiled and I had my dad's practice to take over when I got out of residency, and I've been able to grow that since. During my residency, I really fell in love with dental materials, and I was able to complete a master's program working with the Department of Oral Body Materials, and I fell in love with sealants and composites. And to this day, it's something I'm very passionate about. So I own the only hands-on learning center for pediatric dentists in, I know at least in the U.S. and in Canada. These small classes, and we really try to make sure that we're just really expanding your level of restorative care for your patients. It's a year and a half ago, I moved into a new facility there in my office. My learning center is integrated, and just some photos of my office. I didn't want to do a theme. I kept everything really bright. I wanted it to, feel like, a little bit of a mature practice, but also, fun for children. Really what we're designing for is parents comfortability. My operatories are here. And actually, I'll show you a photo later on tonight. My Sleeper One's built into my ADEC arm there. When I teach courses in the office, that's the classroom there, we convert everything to flat tabletops. and everything's hands-on, one-on-one, and we go over a lot of things we're going to go over tonight as part of the course material. So if you're interested, it's something you're thinking about, pediatricdds.com is my website. Sorry, it's my shameless plug. And these are a lot of things that we talk about during the course. One of the most important slides on here is my contact information. So I pride myself on trying to be as reachable as possible. So I'm going to answer as many questions as I can tonight, but I'm on the phone or under the microscope or, the overhead cam or on Zoom at least a few times a week. So one of the things that I absolutely love about NuSmile is access to help. So myself, any of the KOLs, Jordan or Chris or Aaron, we're here to help you. These devices can have a little learning curve, not because I think they're difficult to use. I think it's just it's completely new to us as practitioners. And I remember when I first got it, I was really worried, how is this going to work? And now it's been enough time where I could not imagine doing anything else. I couldn't imagine using a syringe on a child anymore. So that's my contact information if you wanted to scan the QR code there. If you reach out to me and I don't get back to you right away, please do me a favor. In a day or two, send me a message saying, hey, you promised to return my call or my email and follow up with me. I promise I will eventually get back to you. Just a quick disclaimer. I am a key opinion leader for NuSmile Tech and Dental High Tech. And so I am compensated when I give these webinars, but I promise you, I put a lot more time in than what, and I don't do this, I should say, for compensation. I do this because I feel like when I teach anything restorative dentistry, anything in pediatric dentistry, I just become a better practitioner. And that's really my goal, is after doing this for 20 years, I want to just be the best pediatric dentist possible. And pediatric dentistry can be tiring if many of you don't realize that. I'm sure all of you do if you work today and you're on here tonight. And I just want to make pediatric dentistry easy, and I want to offer the best care possible for my patients. So we're going to do a quick poll here. And Chris, I'm going to turn that over to you.
Yep, got you here. Go ahead and launch this. Just 3 questions, everybody. Basic questions. If you can please answer those, and they are anonymous, but just so we know who has units, who doesn't have units, how you're using them, things like that. So looks like mostly SOAN users, a few non-users yet. Occasional users occasionally falling back to their traditional syringe seems to be just leading that answer or that question. And then what is your delivery method preference? Mostly not sure. So we'll definitely cover that to go over the difference between cruise and drive.
Perfect.
Awesome. Thanks, everybody.
Okay. Thanks for that. That really helps, so we can make sure that we're addressing everybody tonight. Let me go forward. So just quickly again about me. So I graduated my residency in 2003. And actually, I trained in Houston. That's where NuSmile is based. And I was introduced to NuSmile crowns from the beginning. And then I've stayed on, and I actually use, I think, every single one of these products now. And I'll tell you that every single month it feels like that NuSmile has another product coming out to help pediatric dentists. And what's not on here, I think we should I'll include next time, is SDF, correct? So NuSmile has SDF now. Great price point, and also their varnish, which kids love the flavor, and the price point I don't think can be beat on that. And I don't think I'm missing anything else besides SDF and varnish, but something to look into. And also scanners we need to put on here as well. So we have this really amazing group of KOLs, key opinion leaders throughout the world. I know Brian Richards is on here tonight, and he was one of the first people that I went to when I had questions about these units. And like I said, it can be, it's new, right? It's something I almost consider it like with digital x-ray, right? When you first got the digital sensor, you weren't really sure how to use it, and you didn't know if you believed in the technology. And now you look at today, And I couldn't imagine going back to a dark room and chemicals, right? And I feel the same way about delivering local anesthetic via the intraosseous route to children. I just could not go back to a normal syringe. And I would like to announce that it's my birthday today. So what do I mean by that? It's not my birthday. It's my SOAN Sleeper 1 birthday. So yeah, I know Aaron's looking like I should have sent him a present. But I went back and I looked, and it was just over a year ago where it's probably 13 months, but at a year, I'm just past a year where this is all I do. Okay, so I made a decision in my practice once I got my units, and I have a SOAN and a Sleeper 1. I probably spent 3 weeks kind of going back and forth between a regular syringe and my SOAN and Sleeper 1. And today I can tell you that I used to be able to say that I have not picked up a standard syringe to administer local anesthesia to any patient under 14. I blew that because when my associates needed, I was in a room without my Sleeper 1 and she needed the SOAN. So I think I'm at 3 patients. I have to be honest. I think I'm at 3 patients where I've used a standard syringe, but that's a big deal, right? To this day, I really could not wrap my head around giving an injection with a standard syringe to a child. I just couldn't. And this is, I truly believe, the standard of care to deliver local anesthesia to children. So for those of you who are new, I know this can be, a little overwhelming, but you'll get to the point where it's your first birthday and you just couldn't imagine going anything back. So what I did, I thought about this yesterday on my drive home, and I wrote this out. And what I wanted to do is give you some perspective, right? What's my perspective after a year of 99% use of SOAN and Sleeper 1 for local anesthesia? And this is as true as it can be, is number one, almost no tears in the administration of local. And that's including young patients. That is a big deal, right? That's a big deal. When you have that 2 or 3-year-old where you've got to extract a couple anterior teeth, or you've got anterior composites to do on a 2 or 3-year-old, that is a stressful appointment, both for yourself as the dentist and the parent and your assistant, and of course the child. And I can tell you that I don't get crying with local, and I got, it happens, right? I mean, even if you put topical on, they feel if they don't feel the initial poke with the end of the needle, what they feel is pressure and discomfort. And I will tell you that the amount of tears I have in my practice, it's just infinitesimally low. Another big one is oral conscious sedation. I've got an oral conscious and an IV permit. I can give IV meds, I can give intranasal, and the amount of conscious sedation that I do in my practice has dramatically decreased. I still do general anesthesia, but oral conscious sedation, my numbers are, maybe a few cases here or there. And that really is because I can get away with painless injections on young children without issue. 2 or 3-year-old, I wouldn't have believed this a year ago, but I can give a painless injection to extract E and F on a 2-year-old without issue. If you don't believe me, I promise you'll get there. And those of you that have these units and are experienced, they will tell you, don't believe just me, they will tell you that you absolutely can give a painless injection on a 2 or 3-year-old for maxillary mandibular anterior. That's a big deal, right? That's a big deal. I would say my overall stress level for restorative patients has really dramatically decreased. As far as the business side of things, my production has taken a pretty good tick up this year compared to last. And I'll tell you the reason for that is because you can add treatment. One of the things that my team will do is, if we have a certain appointment time and they think that, maybe we are planning that appointment to do 2 or 3 teeth. If they know that child's cooperative at the beginning, even before I get in the room, they may say, Mom, Dad, let's see how patient does today. We've got time. We can, fix other teeth and maybe get everything done in 1 appointment instead of 2. And let's just see how things go. And that adds up. If you do that enough times during the month, where instead of that 2-visit appointment, because you don't want to give bilateral blocks and you've got to treat KL and S and T, you split that up over 2 visits, and that's chair time. Parent has to come back, And it happens almost on a daily basis where I just add treatment. I'm able to add treatment, especially if you have a cancellation. It's just easy because you're not leaving your patient with collateral numbness on their lip or tongue. And absolutely, the amount of one-appointment ops has dramatically increased in my office. So what are some of the things we're going to talk about tonight? We're going to go over a little bit of the basics because I believe there's maybe about 15 of you that are new. And really what I want to hit is some of the common questions. And I've added some other things tonight. We're going to talk about how do you talk to parents. I think that's an important one. I want to go through with you the mantra that I use every time I give an injection, just so I don't forget anything. We're going to talk about local anesthetic choices. That question comes up a lot. And we're going to go over some cases and some more cases and then questions from there. Okay. My personal opinion is that electronic delivery of local anesthesia that is using one of these devices with a digital, I call it a digital pump. This should be the standard of care. Okay. We're going to talk about why, but and it's the growth that I've seen both in private practice and residencies has been absolutely tremendous. And this is the way I can really provide the best care possible. I want to give the best restorative care. I want to make sure that my patients are comfortable. I want to make sure that everybody's happy at the end of the day. And if I can get through that appointment and I know that I delivered a safe administration of local and the child's happy and the parent's happy and my team member's happy, everybody's had a good day, right? So what are some of the benefits? I can truly tell you in my heart of hearts that 8 out of 10 or 9 out of 10, I don't think I can say 10 out of 10, but it's getting close, is a pain-free injection, right? That means, and not even pain-free, I would say sensation-free. 9 out of 10 times, I know I can sit down and I can numb, for example, here on RS and T, and I know I can give that stage 1, that stage 2, and I can deliver a half carp or quarter carp without the patient feeling a thing at all. So I think it's not only the pain, but it's also just no sensation. And that does nothing besides make that restorative appointment much more simple for you, right? And sometimes, and I want to make this point for those of you that use these units, is once we pass the cortical plate and we're injecting into the cancellous bone, there are no nerve endings there, right? Now, there's, of course, the tooth has a nerve in it, but in the actual cancellous bone, what patients feel is pressure. There's nociceptors there, but there's not pain receptors. So sometimes you may have a child, move or make a sound, and I know in my heart of hearts what they're feeling there is pressure. The thing that we need to remember about these units is the sensors are so sensitive that they are giving that drop by drop administration of local without building pressure. Many years ago, I tested out the X-Tip and some of those other devices, and I could get the initial penetration to the bone, through the bone, really without sensation for a lot of children, but it was a pressure every time. Manually, as you push, they feel it. No supplemental lingual or palatal injection. It's a one-time thing. I have to give one intraosseous injection, and that's all. This, I could not understate how amazing it is not to have. No, I truly believe I can tell you that in a year, I have not had a numb lip or a numb tongue. I used to tell patients, well, let's wait an hour to an hour and a half before you can eat. And those children right before lunch, you could see them not being so happy, and mom's not so happy or dad's not so happy. But now, unless I'm, have extractions or something, I'm telling patients, go ahead, right? Because the teeth may be numb, but you will, if you do things correctly, you will not have a numb lip and you won't have a numb tongue. Bilateral mandibular treatments. I would never think about giving a bilateral block. I think it's somewhat cruel for a child, and now I'll do bilateral mandibular treatments all day, every day. Far fewer appointments. When we say immediate action, that is one of the magic responses that you get with intraosseous local anesthesia. Is once you finish that injection, the needle comes out, handpiece you pick up, and you start working. Now, it's a little disconcerting when you first do this. I was a little concerned that that truly was going to be the case. And just a quick suggestion here if you have a patient that you've already done a fair amount of treatment, or you've completed one half of their treatment with a standard needle, and then you go to IO for the other side, please make sure you tell the parents that, there's a difference that day, because I did have one mom immediately. She wasn't so happy. She thought I was not waiting enough time for that child to be numb, because the appointment a few days before, I did a standard block and I waited. And then second appointment, I used IO, and mom thought I was just, I think maybe speeding things up in that appointment. I had to explain to her, no, they're immediately numb, and it truly is immediate action. And there's no delay between that anesthetic delivery and active treatment. It really is finish your injection, come out, maybe rinse the patient's mouth, take out a tooth, or go into the pulp really right away. So better behavior management, less stress for everybody, less post-operative side effects, and parents are happy. And if parents are happy, everybody's happy, right? This is the case that really sold me, that I knew that this is what I was going to do for every single patient. I'll go in a little bit on this case later, but NOPQ needed to come out. I gave one intraosseous injection here, half a carpa, this was septa 1 to 100,000, and took out NOPQ without sensation. Patient didn't move, didn't feel a thing. And previous to this would have been maybe 3 injections, right? Numb, and then maybe lingual, and probably some tears, right? Okay, so no collateral numbness. No collateral numbness really means no collateral numbness. I mentioned it earlier. I am, as far as I know, in a year, I have not had a numb lip or a numb tongue. Now, because this is a mastering course, I do want to mention that what happens if you feel like your patient has a numb lip afterwards. I will tell you, when I've talked to doctors that have experienced that, it was because that first stage they were giving too much local, right? And we'll go into detail about that, and I'll show you the stages of how we administer an injection. But if you follow the steps, if you follow all the rules, you should not have a numb tongue or numb lip afterwards. Okay. The first thing that we need to do is get some instructions. So for those of you that are new, that don't have one of these devices, or that you have a device and it's still in the box, here's the steps that you have to follow. Now, I've probably spoken to 3 or 4 doctors that had many, many questions, and I came to find out that they, delegated the onboarding and training to one of their team members. Well, you need to do this, right? You can do it with your team, but this is a device you're going to be using every single day. You need to do that onboarding. NuSmile and Dental High Tech has spent a long time and many iterations to make sure that this is absolutely the best training that you can receive. And if you actually go through this whole process, you do the virtual meeting, and if you have a couple questions here or there, that's fine afterwards, but the majority of the information you should get. And if you go ahead and finish this, you finish the whole onboarding, you will get a free box of needles. There's lots of help out there, okay? So everybody, they introduced themselves already, Chris and Jordan and Aaron. If you need help, you can scan the QR code there, emails and phone numbers, and I'll show this again at the end. Facebook group. For those of you that are not on the Facebook group, I would highly encourage you to join. It's a very supportive group. There's expert users, there's new users. You can go ahead and even if you don't own a unit yet, you can go ahead and sign up. What I suggest is, if you have questions, look up, before you post, do a search. We've had this up now long enough where I think a majority of the questions, things like Erin just did a video segment on cruise versus drive. She did one on how to check your settings. So there's already really good topics that are here. But if you have a question, please post it. So what are we going to do tonight? Tonight, I want to give you as much information as possible so you really feel like that you've mastered the use of these devices. So let's back up a little bit at the beginning, because there are some new people here. Here's the key message. Administration of local anesthetic via the intraosseous route is not much different than what you've been doing since day one of being a dentist, okay? So when we gave a standard infiltration, when you lifted that patient's cheek up and you, in the vestibule, you delivered a half a carpule there, what you need to realize that eventually that bolus of local anesthetic got to the nerve somehow. Or how did that happen? Well, it had to perfuse through the periosteum, right? And once it perfused through the periosteum, it went through the Volkmann and conversion canals in that cortical plate through the cancellous bone to the apex, right? It had to get to the tooth somehow. But if you step back and think about it, that's number one, a long span of where that local needs to go. And number two, you're delivering local in an area where we don't necessarily need it. Where I need it is at the tooth, right? I don't need to numb at first. I need to numb the periosteum so I can give that intraosseous injection. But really my goal, if this is just I'm treating teeth, is I need to get that solution to the apex of the tooth. So now the difference with, and this is how we gave that local anesthetic, right? Infiltration through the bone, conversion canals, and Volkmann canals, and then we get into that cancellous bone. But really where we care about is the target, and the target is that apex of the tooth. That's where I want to get my solution, right? So what do? I call this, passing that golden rope. You go, I haven't been to a nightclub for a while, but when you get to the nightclub, if you know people and they move the velvet rope out of the way and they just let you in the back, this is what we're doing, okay? I know it really is. So we are passing periosteum, we're passing the Volkmann canals, we're passing the conversion canals, and we're delivering that bolus of local anesthetic in a targeted area. We're giving it close to the apex as possible. Now, this is a two-way street, right? So the nice thing is not only do we get to deliver that local by the apex of the tooth where that directed local anesthetic, but now our solution is going to work in reverse. So we're going to go back through the conversion canals, back through the Volkmann canals, and then we will get out to the soft tissue. And once you deliver your bolus of local anesthetic, everything around in that area is going to be numb 360 degrees. So for those that are new, and again, there are a fair amount of people on here that are new tonight, let me show you how this works. This is just an animation. So we have three distinct steps. Now, the first step is we've got to numb the soft tissue in the papillary area first and the cortical plate. Once that area is numb, and we're only talking maybe about a 4 millimeter wide circle, then we can go on to step two, and that's the penetration through the bone. The nice thing is with children, even teens, that cortical plate maybe is 1.6, 1.8, the very max millimeters thick, and we can pass our needle as close as the apex as possible. We're able to give a smaller bolus of local anesthetic because we're delivering exactly where it needs to go. Okay, so what are the three stages? Number one, of course, we need to numb the papilla first. If you were to just take the needle and put it right through the papilla into the cortical plate, we're not going to have a happy patient. So first step is that periosteal anesthesia. The nice thing is it's a highly innervated area. It gets numb very quickly, very quickly. And then our MBP, our manual bone penetration. Now for adults, we can't necessarily do this, right? But with children, we've got thin cortical plates. We're able to use that special Effitech needle, pass it through the cortical plate, and then we deliver our anesthetic exactly where it needs to go. This is a great video shot by Paul Bond. And I want to just play this for you, and then we'll talk about it in a minute. So this is our stage one. We're entering at about 15 degrees. You notice the D on the needle, it's facing out. And we're delivering enough local anesthetic here to ensure about a 4 millimeter diameter circle, but we want to see blanching. If we have enough blanching there, and this takes, I would say, anywhere from 5 to 10 seconds. If I've got profuse blanching just in that area around the needle, I know I'm able to move to my next step. So that's step one. We're going to come out now. We're going to change directions for a manual bone penetration. Press, 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 and through. And now we're at the third stage where we're delivering our anesthetic drop by drop. Now, dependent on the procedure and the age of the patient and the anatomy will be dependent on how much local anesthetic that you're going to give. I'll give you some general guidelines. We'll talk about it in detail here in a little bit, but I'll tell you that, let's say I'm doing back-to-back restorations in S&T and maybe a small occlusal on number 30, I'm typically giving about a quarter carp of local anesthetic. when I first started this whole process in my journey, I was giving a half, and then I found I started backing up a little bit, and I just didn't need to give as much local. And there we go, our injection's done. So I would say for most patients in my office, on average, it's a quarter to a half carb in that quadrant. Okay, we're using a 9 millimeter needle here. So there's a couple key points in this slide. Number one, some new dentists to this procedure are worried about the tooth buds. Please don't be worried about tooth buds. If you're able to get that needle down to the tooth bud, we've got an issue, right? You have to imagine it's a 9 millimeter needle, and we're not passing the entire needle down to that hub, right? We want to keep at least 1 to 2 millimeters out. So at that point, we're about 7 millimeters. You are nowhere near a developing tooth here, okay? For older patients, and it does come with the longer needles, like both the 9 millimeter and Chris, I'm sorry, what's the
16 millimeter?
16, thank you. I don't even know, because I think I've used it once I got out of the box, and that's it. You can technically give a block with this, but really I've only used the 9 millimeters 99.9% of the time, okay? The needle is a specially designed needle that we're going to show you here in a minute. So we need to select how much local anesthetic we're going to use, what local anesthetic we're going to use, and we want to inject as close as we can to the target. So why can't we just do this manually, right? Why do we need, and I saw someone post a long time ago, they said, well, I'll just give this injection, I'll get a small needle and just give a manual injection. Yes, you put one of these needles on a standard syringe and screw it on tight and pass it through the bone? You could, but I will tell you that 9 out of 10 times your patient is going to have pain there, right? You have to be able to use an electronic delivery. This is giving drop by drop anesthetic, okay? And so if you were to give a fast injection here manually, the problem is, with that pressure, that local anesthetic is going to diffuse through the bone, right? We need to be able to give directed amounts of local anesthesia, that local anesthetic in a defined area. And this is where you've got to have an electronic device. Now, there are other devices on the market besides the SON and Sleeper One that are electronic, but I'll tell you that this is the only device that is FDA approved to give intraosseous local anesthesia. You don't want to use those other devices, okay? So how does this work? Once we pass through the plate and we start giving our local anesthetic, where does it actually go? Now, this is an adult skull here, but the key point is that on the maxilla, there is not a bias of flow. So if you were able to get through the cortical plate and deliver actually into the cancellous bone, so this is osteocentral delivery, we can numb 2 teeth mesial and 2 teeth distal. So there's not a bias of flow. Once you inject, you're going to have some move mesial, some move distal. Now in the mandible, it's slightly different. There is a bias of blood flow from distal to mesial. So in general, what you can count on is 1 tooth distal and 2 teeth mesial. Let's talk about with pediatric population, because that's mostly who we're using these devices on. So if I were to give, we call this, an electronic block, basically, is I know for a fact I'm going to be able to have profound local at least 1 tooth distal and 2 teeth mesial. Okay. I will tell you that if this patient had their 6s, I would feel comfortable having fairly profuse local anesthetic on the 6s as well. But you can definitely count on 1 tooth distal, 2 mesial. On the upper arch here, it's typically 2 and 2. All right. So what are the 2 devices? So we have the SOAN and Sleeper One. Many people, I would say, are, Chris and Jordan, would you say the sales are more heavy towards the SOAN than Sleeper One?
Yeah, there's definitely more popularity with the SOAN.
And one of the things I wanted to cover tonight was, which device do I use? I think it's important to talk about the cost. Okay, so we have the SOAN, which is portable, and then the Sleeper One, which has a cord. Personally, I have both. I actually like the sleeper one. I like the fact that I like the weight of it. Now, you can't move it from chair to chair. I have it wired into my chair, but I like the fact that I can see the display lights 360 degrees. If you're only going to buy one, which most people start with one and they wind up buying multiple of them, but if you're only going to buy one, you're going to move it from op to op, you're going to wind up buying the SOAN. Okay. But many people start with one and realize they don't want to carry it from room to room. They don't want to worry about when their assistant's dropping it. Once you start going with this, you'll likely wind up buying two or more of them. Okay. So there's our SOAN. Very simple. There's the device, charger base, the cartridges where the local anesthetic is placed, and the needles, and it does not come with a koala bear. All right. Instructions. Please, 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 if you have a SOAN or you have the Sleeper One, please go through and read the instructions, especially if you need to change some settings. So I wanted to quickly go over tonight what are some of the settings or the most common settings that people are going to change, okay? Number one, here's the unit itself, and then we have the pedal, okay? This pedal is, uses when you step on the button, it's not recharged at all. It just sends it has current built in, and it sends a wireless signal to the base. But on the SOAN itself, you can see injection speed. We're going to mostly leave this in B for bone or B for blue here. Okay, I think it's blue to me, and I leave this on blue. The only time you're going to change this to high is if you're going to give an infiltration or a block, which I rarely do. The only time that I'm changing this these days, and this is one point I wanted to make for those of you that have these units already, if I have an over-retained tooth, let's say R and S are hang on by a thread, I don't give an intraosseous injection for that. I just only give soft tissue. And when I do that, sometimes I'll just turn it on onto high mode just to give speed wise, I'm not too worried about it then because I'm not worried about the patient feeling pressure in the bone. But 95% of the time, I'm leaving it in low. Okay. Big pedal and small pedal. One important point is you really need to step in the middle of this pedal. When you situate yourself and you sit, if you are you place your foot and you're not directly on the middle of this pedal, sometimes I have noticed where I hear a click, but it doesn't engage. So please make sure that before you sit down, and I'll talk about my mantra here in just a minute, that you have that pedal in position where you can know exactly where your foot is, okay? And if you wind up stamping on both, the small pedal wins every single time. So if you feel like you're taking a very long time to deliver a quarter carpio of local anesthetic and it's been 2 minutes and it's barely moving, it means you're probably stepping on both pedals or you're still on the small pedal there. Okay. As far as the options go, just really quickly, the one thing I wanted to point out, and Aaron mentioned this tonight, there are two different modes that you can place your SOAN and your Sleeper One. First is cruise, and the second is drive. That's up to you. I personally keep my units on drive. What is drive? Drive means it's just like a car. So you step on the gas and it delivers, you come off the gas and it stops. Cruise mode is a set delivery amount. So let's say you have your unit set on cruise and you have a setting for a quarter carpio. You step on it once and it's going to start, and it will, and then when you get to quarter carp, then it's going to stop. Okay. Chris or Jordan, what do you find these days that most dentists are using? Is it cruise or drive?
Most are in drive.
Most in drive. Yeah.
Most are in drive.
Have control of it. I leave it on drive. Now, time for shutdown, that one I wouldn't worry about. I also wouldn't change the speed. We do know that when you step on the pedal, it's going to start slowly, the large pedal, it's going to start slowly giving that injection. And after time, and when it knows that there's not too much resistance, it'll speed up. But just keep this setting where it is. I wouldn't change it, okay? And we talked about the colors already on blue or pink. Okay. Sleeper One, the thing I like about this unit, I do like the weight in my hand, and I do like the fact that I can see the colors all the way around. Settings, there's a few less settings on here, but again, this is all in the manual. One thing I do want to show you, very clean setup. This is how I have my Sleeper One. We actually wired the power cord in the arm for the 8X chair. So I just pick it up out of the handpiece and use it, and then I go to put it back. One point I want to make here, you see how the Sleeper One is in the upward position. If you don't have a carpule in here of anesthetic, you can leave it like this. But you don't want to leave it in this position if you have a carp of local anesthetic. It's possible that you could have some leakage in that carpule of local anesthetic, and it could wind up dripping down into your unit. So if this is loaded and ready to go, we actually have it the other direction. Let's talk about some FAQs. This one I added today. Dr. Miranda had posted this online with how do you tell the difference between the cartridge for the Sleeper One or the SOAN? This is actually, you can buy this at Amazon, very inexpensive. They're just little autoclavable instrument rings, and you can label colors, one for SOAN, one for Sleeper One. What I use for my units actually is because I have it in Drive, you can't necessarily see exactly how much of that of the solution you've given. So we just take this autoclave tape, and I have it marked at a quarter, a half, and 3/4. And these autoclave tape, it's totally fine to use. And that way I know if it's as soon as my plunger hits here, I'm at a quarter, then a half, and 3/4. Someone did ask when I showed them this photo, they said, well, there's a lot more room here. Remember that your needle actually sticks into your carpule of anesthetic, and it's actually almost to about here. So I promise you that is an even amount of quarter, half, 3/4, and a full carp there. All right, so what's my mantra? My mantra, and I do this every single time so I don't forget. Number one, when I come into the room and I sit down, I look to see, is the power on? If you leave your unit in the mode that it comes with, it is set so you can give 50 deliveries. Okay. Number two, so power's on, I've got it in my hand. The reason for that is I don't want to start my first injection, my first part of my injection, and realize the power's off, right? And you've got to take it out and give it another injection. Number two is plan. I'm going to look at my radiographs every single time. I'm going to choose which local anesthetic I'm going to use. I'm going to review with the parent, and we'll talk about it in a minute. Number three, pedal. Is my pedal in the right position? I don't want to go ahead and inject or get ready to inject that first phase and then realize I can't find my pedal, because if you're hunting and pecking it with your foot, you're going to wind up pressing that needle into your patient farther than you want. And then, is my patient in the right position? Is my foot in the right position? Is everybody ready to go? So power, plan, pedal, and position. I added this tonight, and I think this is important. Once we first get our units, many people are very excited, right? Oh, I've got this new thing and I want to talk about it. The truth of the matter is, parents don't necessarily like things that are new. They don't want to feel like you've got some new device that's, not very tested and not used on the market. So I would suggest, I think it's important to let parents know about what you're using, but what I let them know is my explanation is I have, a new device that I'm using to give local anesthetic. It's the same drug that I've always used. Okay. I don't want them to think it's some brand new drug in the market that I'm experimenting on their child. It's the same local anesthetic that I've always used. It just happens to be a digital pump. It's a way of delivering that same anesthetic in a fashion that's more comfortable for their child. So I've seen some offices have a poster that they made on their wall. I personally have QR codes on my wall, and we have handouts for the SOAN and Sleeper One in that folder. How you discuss it with your patient, I've heard some people call it a magic wand. Sometimes I'll either say magic wand, or I'm going to take the temperature for of my patient. Parents may ask questions about it, and I just keep it very simple. We're using a device that's a digital pump. It makes it more comfortable for your child, and I leave it at that. NuSmile, I would encourage all of you to buy these. And NuSmile did a really good job with checking in with many pediatric dentists. on making sure that there's really good information here for parents. And one of the things that I do as well is we use these brochures, and I also have my card, my contact information, and our new patient program, internal referrals, and I just give that all to the parent. I don't like to kind of talk about that stuff, but they may be excited about it, and I hand it all to them. It's a great way of building that internal referrals to your practice. And I let patients know, I mentioned this earlier, I let them know they can eat and drink right away. Okay. What are the two local anesthetics that we use here? Number one, so we're using 4% articaine for everything. Okay. 90% of the time I'm using 1 to 200,000. The only time now, after a year of doing this, the only time I'm using 1 to 100,000 is for extractions where I really want to have as much density of delivery of local anesthetic in one place. But I think just make your life easy and just buy the 1 to 200,000. You do want to make sure that your staff can tell which one's which, and there's a color on each one, and they're different. Especially for older children, for teenagers, if you're delivering, you're using intraosseous local anesthesia, I would suggest you use the 1 to 200,000. Because if you remember, for those teens, is the needle is short enough where you may only be getting that local delivered in the interseptal bone. You're not getting it all the way down, into the space of the interseptal, or of the cancellous bone. So I definitely we used 1 to 200,000. A few doctors have made the comment where they feel like patients have pain. Let's say they're doing extractions right away in the office. And my theory with that, and I'm 99% sure, and I'm 100% sure I should say, these kids were always having pain post extraction, right? The thing is we know that the working time of intraosseous anesthesia is a little bit shorter, right? If we're not giving a block, we're not perfusing and getting that whole nerve numb, this is going to wear off a little faster. So 1 to 200,000, that's an important number here. It's approximately 35 minutes of working time. 1 to 100,000 is a little bit longer, 45 to an hour. So if you are, even if you're not doing extractions, but you want to increase the amount of working time, you may want to think about using 1 to 100,000. I just keep it simple in my office, and I use the 1 to 200,000 most of the time. You may want to think about giving Tylenol or Motrin before the appointment. I know many offices routinely do that. I do that now with extractions. Either I'll have parents give it at home, or we'll just deliver it, administrate it in the office itself. Okay. We don't have to worry about getting to that developing tooth, bud. This is only a 9mm needle. With teens, again, I want to mention it one more time. I really would suggest using the 1 to 200,000. Please remember that because you have a shorter needle here, with teens, you may not get 1 tooth distal and 2 teeth mesial, or 2 teeth mesial and 2 teeth distal. Because you're delivering mostly in the interseptal bone because it's a shorter needle, I pretty much will guarantee when I do this that I'm going to have 1 tooth mesial, 1 tooth distal. If I get anything more than that, then that's a bonus. How much local do we give? In general, if it's patient has their 6s and other primary teeth, if I'm just doing back-to-back composites, I'm giving a quarter carp. I don't think there's anything wrong with giving a half, but generally what I've found after doing this hundreds and hundreds of times, I'm okay with a quarter carp. If I have to think about it, if I'm really worried that I just, patient's going to feel anything, you can give a half. If I'm into the pulp, I'm going to give a half a carp. So anywhere between that quarter and a half. I don't think I've ever given, I've never given more than half a carp in a quadrant. Nope, I haven't on a child. I haven't needed it. To be honest, I haven't needed it. Let's talk about position of the needle. I want to go forward here just a little bit. And I want to talk about access, because doctors at first, sometimes they're worried about, well, if I'm right-handed, how do I get the left-hand side? Very easy. And I learned this from Eric Hans, thank you very much, is you can give palatal delivery of IO local anesthesia, no problem. We're, in dental school, I think it was the last time I actually gave a palatal injection, But in my experience, there's no different sensation whether you deliver that stage 1, 2, and 3, or that stage 1 and 3, either on the facial side or the palatal side. So I will routinely, if I'm working on I&J, I'll routinely give a palatal injection here. Now, again, you're not giving in the palate where you normally would, like we learned in dental school. It's just you're following your same rules as far as horizontal delivery for that first stage, then your manual bone penetration in the exact same area. You just happen to be accessing via the palatal papilla area, and it works, and it doesn't hurt more. And don't be a baby. Just try it. I was worried about it first. Once I did it once, and the patient did not react, then I had no problem, and I do this almost on a daily basis, especially if you have an infection. So many doctors are worried about, well, how do I get, if I don't have much bone around an infected tooth or two in a quadrant, how do I get good IO access to that? We don't want to be injecting into that infection site. Just go ahead and give it on the lingual. All right. Pain. This one comes up a lot. What we need to remember on that stage 1 is if you start mid papilla here, it's easy to get heavy-handed and start drifting and getting the tip of your needle close to, in this case, number T. And if we get close to the PDL, your patient's definitely going to feel it. So what I suggest is split the papilla in half, and then laterally, mesially, about 1 millimeter or 2, enter at that 15 degrees. Then as you slightly press that needle forward, actually you're moving it distally, you'll end up at the end of that stage 1 with delivery right at the middle of that papilla. Okay, 15 degrees. That's another important point here, is you really want to only be 15 degrees away from the tissue. Anything more than that, and you're more likely to have pain there. Please remember that D is facing out. You saw the D in the animation in the beginning, that D's got to face out. And the reason being is it's on the opposite side of the bevel. So we're coming about 15 degrees, D is out. If your D is the other direction, your patient most likely is going to feel pain there. Lights. How many lights are okay? This one comes up a lot. 1 light, I'm fine. 2 lights, I'm okay. 3 lights is actually average resistance. Honestly, and it was the first couple months when I did this, I actually thought 3 lights was a bad thing. I started backing off. That's an average amount of resistance. Now, if you get to 4 lights, what do? 2 things. Number 1, I'll just back out slightly, and then I'll continue giving my injection. The reason why I don't want to come off my pedal right away is, remember, there is that ramp up, right? And if you come off your pedal and you step on your pedal again, you're going to have to start that ramp up speed. So I will just back out a little bit, or I'll slightly rotate. You need to remember that your units will always keep you safe. If the unit feels like there's too much resistance, there's too much back pressure, it'll actually back out your plunger. So you get to 4, back out just a little bit. If that doesn't work, think about changing out your needle. You may wind up having a little bone in there. You can have a little bony plug in the needle itself. And so you have to think twice, just take it out, put a new needle on. And I would suggest not changing your pressure curve here at all, okay? And this is what I mentioned about the pedal. For some people will complain, they'll say, well, this injection takes longer. Well, guess what? It takes the amount of time that you're supposed to give an injection. We're supposed to be delivering local anesthetic about 1 milliliter a minute, right? I will tell you that a vast majority of people probably with a standard syringe give it much faster than that. And that's why people generally have pain. So just stay on the pedal, come out a little bit, reposition, and then typically the lights will decrease. And if it don't come out, to put a new needle on, you can go back into that exact same hole that you had before. Okay, if you're stepping on the pedal and it's not responding, many of us have these brand new dental chairs. These things weigh, 600 pounds or so. They're metal and they're leather, or there's cardboard in here. There's sometimes wood. And if your pedal's not responding, it may be that it's just sitting right under your chair. There's nothing wrong with your unit. It's fine. Move the pedal to the side. Try it again, and typically it's not going to have a problem. But remember, there is a radio wave that's got to get from your pedal to the unit itself. Again, I just want to make this point. Working times. I don't want everyone to forget this. Is at 1 to 200, you've got about a half an hour to 40 minutes or so. With 1 to 100,000, that goes up pretty much to an hour. So what does that mean? I used to, before, let's say I was working the right side, I'd give an infiltration and a block. Now I just work one quadrant at a time. Unless I'm, it's going to be pretty fast. Let's say, like today I did on a couple patients KLST. I just gave my local on S&T, did the restorative, moved to the other side, gave my local, did the restorative. You can, and I typically, if you're using an isolite, keep your isolite in the entire time. That's one of the greatest ways of not having your patient taste anything, because we know that's sometimes that can take our appointment, make it very difficult. They may not feel anything, but it may taste bad to them. Put your isolite in and just go ahead and give your injection. You start working right away. And I typically, if I'm using an isolite, I put it at the very beginning of the appointment. It comes out when I'm done with that quadrant or if I'm moving to the other side. If you're worried about, the local anesthetic wearing off a little bit faster, your patient's having pain, just go ahead and pre-medicate. Give them their OTC pain medication, either Motrin or Tylenol, ahead of time. If you're really worried about pain on top of that, you can repeat that IO injection. So let's say you worked on a quadrant for 40 minutes, you can go back into the same hole and deliver, another quarter carpule just to make sure that you extend that local anesthetic time for another, half an hour and 40 minutes. This is another big point about care of your units. Number one is you don't want to leave your SOAN or sleeper one in this position. So for the SOAN and the charger itself, don't leave it like this. It's possible you could have a crack in your carpule of anesthetic, and these electronics are highly sophisticated, and of course they don't want to get wet. So once it's charged, just go ahead and put it on the counter. This is what you don't want to do. So if you have it loaded, you want to leave it in this position, and that's again built into my chair. Switching needles. If you try to give your first stage and you just cannot, your third stage, your second stage, and you can't penetrate through the bone, don't keep on trying. You can go ahead and put a little bit of pressure, rotate, but if you can't get through, come out, put a new needle on. This is under the microscope, and I just took these pictures not that long ago. We have to remember the Effitech needle is very sharp and long, but along with that amount of sharpness, it does bend after one use. So typically, I just pick up a new needle every single time. One point I want to make with delivery, because I did have two doctors actually in the last couple of weeks ask me, and they saw these slides of delivery with cases, and they asked about, well, can you give stage one in more of a vertical position like this, right? And I remember asking Dr. Prin this early on, why do we give a horizontal stage one and then change position? The reason for that is it is much easier to accidentally slip and bump into that periosteum, right? And if that patient doesn't have complete local anesthetic delivery ahead of time, you're not going to have a happy camper. So especially with children, I would recommend, not going at this angulation. Now on the palate, sometimes just from access, you may need to, but you've got to be careful. The recommended way of giving that first stage is coming in horizontally. Okay. Upper anterior, one question we get asked a lot is about canines. We know the bone over the canine eminence is much thicker, so I will typically give distal to the canine. So between the C and the D, I find the mesial of that tends to be a little bit more difficult. Upper left quad, again, you can give it palatally. Just be careful in this orientation. I tend to give that stage one the same way every single time in a horizontal direction. Could you give it in this vertical direction with your stage one? You can, but just be careful. It is much, much easier to over penetrate through that soft tissue and bump into the periosteum before that patient is numb. Lingual on the lower arch, you can give it on the lingual and the lower arch too. I would typically, this is kind of, we call it an average, this is a quote unquote, intraosseous block now where you're giving one stage and your second stage. Remember, you can give it on the lingual surface, especially if you have an infection here. You need to make sure that we're delivering in organized bone. So if you have an infection, or let's say you don't have really any roots that are here, and it's mostly soft tissue, and you want to make sure you're getting into that bone, I will rotate and give on the lingual surface. The truth of the matter is it doesn't really matter. As long as you penetrate through the soft tissue, through the periosteum, into the cancellous bone. You can give it buccal, you can give it lingual. You're still going to have the same results. Okay. We talked about already about which local anesthetics that we're going to use. And I want to make one more point and then turn it over to questions here quickly, is that what do you do about, let me go forward. Okay, this one comes out a lot. Aaron, I know you've gotten a fair amount of questions the last couple of weeks about infiltration or IO for over-retained teeth. Personally, I don't give an IO here. If that tooth is only held in by gingiva, I will take my pedal, I'll put it over to orange mode. You could leave it on blue if you want, and I'll only numb the soft tissue. I just find I don't have to give an IO injection if it's an over-retained tooth. Aaron, is that mainly the question you were getting about over-retained teeth? It's just IO versus infiltration?
Yeah, how's that?
Okay, perfect. And then what do we do about just, let's say you have a pulpotomy that you need to do in that quadrant. That's when I go more to a half a carp. So in general, if these were back-to-back composites for a 4-year-old, I'm going to give a quarter carp. Nothing wrong with giving it a half, but my rule is if I'm into the pulp, I'm going to a half a carp with 1 to 200,000. And actually, very last case I want to show you. What do we do about infection? Well, perfect case in point. You don't have organized bone here. You've got a large infection both on S and T. At this point, you may want to give, just rotate the patient slightly towards you and give it lingually. There's no problem, no difference here giving this buccal or lingual penetration in through the cortical plate. As long as you're through the cortical plate into the cancellous bone, you're fine. All right. I think that was the last case that I want to show. I want to fast forward a little bit here. And these questions we've already gone through. And I think we have enough questions. I want to go through that tonight. We've been through these. Okay. I want to, again, put this up. If you have questions, anything that we didn't go over tonight, please reach out to Chris or to Jordan or to Aaron. Phone numbers are here. If you want to purchase a unit or 2 or 3, they'll be more happy to help you with that. Pricing wise, the prices on there earlier. I don't believe there's any differences. Some people reach out, well, should I wait on buying a unit? Are the prices going to go down? They're really fixed. These have sold so well. I haven't seen any changes to pricing over time. Upcoming workshops for those of you that want to not only train more hands-on with these devices, but also learn about all the other products that NuSmile makes. Los Angeles is coming up. Chris, I believe there's room still there. And
room
that's
for all of them, yep.
2-day course. I'm going to be teaching, I put my little picture there because I will be at the Newburgh course, but there's Fort Lauderdale and Boston. They really pick nice cities. I know Newburgh, this is at the Allison, which is absolutely beautiful winery. So it's a good way to write off a vacation. And that's one of the reasons why I'm going to. All right. I want to sincerely thank everybody for tonight. We're right at 6:05, so that's perfect. We're going to open up things to questions, but please remember, I'm going to put my contact information here again, so you have it. Please reach out to us if you have any questions at all. If you are having, the last thing I want to say is if you're having an issue, let's say your patient's having pain every time you give an IO, please take a video. Ask permission for the parent and take a video of giving that injection. It's much easier if one of us can see you actually in action. We can see your patient positioning. We can see how you're holding your hands, how you're holding your units versus just describing it to us. Okay, so I'm going to put my contact information back up. And then Chris, we're just right over an hour, so I'm going to turn things over to you.
Awesome. Yeah, I do want to mention that we are offering 10% off through the end of the week. So if you guys are on the fence or anything like that, we are offering 10% off of units.
I didn't get 10% off mine. Is that all right? Well, that's I have yet to see that come about. So thank you for doing that.
Yep, 10% through the end of the week through Friday. So with that, I will go ahead and start with the questions. Basic questions. Again, guys, if you do have questions as they come up, just put them into that Q&A. We'll go through them as they come in, but just a couple for right now. Really good basic questions to go back and cover really important things. First one is about injecting into adults. Dr. Solomon, if you could please talk about some of the age ceiling that you've worked with and kind of your experience there, that'd be great.
Okay, so thank you for asking. The thing we need to remember is that manual bone penetration is really designed for primary to mixed dentition. Okay. I know in my heart of hearts for patients 14 and under, I'm like almost a 99, 100% success rate of being able to manually penetrate that needle through the bone. I consider anybody 14 and up a bonus. Now, I would say I don't give a lot of blocks in my practice anymore. I was thinking about this the other day. Even 18, 19-year-olds, it's not guaranteed, but typically females, not always, but females may have the cortical plate of the bone may not be as thick. But if I have a 19-year-old big linebacker guy, I'm usually not going to pull out my sew-in or sleeper one. Okay. So that's the first thing. I would say 14 and under, I don't have a problem, giving that using manual bone penetration. But number two, as a reminder for a teen, just remember that because it's a 9 millimeter needle, you're not going to be giving most of the time a osteocentral injection. You're not delivering that local anesthetic near the apex of the tooth or really in the heart of that cancellous bone. You're mostly in interseptal bone. So you can pretty much bank on one tooth distal and one tooth mesial, but I wouldn't 100% guarantee that you're going to get anything more than that. You may need to then give an injection, go one tooth distal and just give the injection again. After that first stage, the soft tissue is numb typically, and then just go ahead and move on down the line if you have a teen. But I find, I quote that kind of 14 and under, no problem, but even 15, 16-year-olds, 17-year-olds, I use this. Adults, it's just not guaranteed with these units.
Along those lines, too, another question just came in. Is it equally effective across different racial groups?
It all comes down to bone level. That's really, if you just think about bone density, if you're working with, and some people may have a practice that, has a certain population from different areas of the world. If you find those patients have denser bone, you're going to have more of an issue getting through manual bone penetration. But 0 to 14, really, I can't think of any patients in the last year where I could not, use one of these devices, manual bone penetration.
We've had a couple of questions about the 3-step process and angulation again. If you wouldn't mind covering that real quick again.
Show you very quickly.
Let's go ahead and do that.
All right. Blur. Okay. I just wanted to play with my toy here with me. Really, when it comes down to. Okay. So let's just go through a standard injection. So how do we do this? So my patient, and I'm going to pretend that this is my patient sitting in the chair. I'm just going to rotate a little bit like this. Okay. So we're going to go ahead and deliver an injection, and we're going to numb S and T here. And I'm going to just grab my pedal and walk you through this. So first stage, number one, for my sew-in, I want to make sure that my light and the D is aligned in the same angulation. I need to be able to see both. So if that D is rotated around, I'm not going to be able to see my light. So please make sure you ask your teams, don't over tighten your needle here. So I have my D and the light in the same orientation. I'm just going to hold this so we can see. You need to make sure that you're holding either your sew-in or sleeper one like a pen. The number one reason why people bend needles, and some of you will bend needles at first, is a failure to really grasp as close as you can to that the hub of the needle itself. So I'm coming in, my D is facing out. I'm at about a 15-degree angulation, and I start. If you remember, we talked about the middle of the papilla. I'm going to split that papilla in half, and then I'm going to go just slightly mesial to that. And again, all of us get heavy-handed. If you start here and you start injection, it's easier to drift forward, and the tip of that needle can get too close to the PDL of, in this case, the E. So I'm going to start about 2 millimeters away from mid-papilla. I'm at about 15 degrees. And I'm going to enter for my first stage. This takes about 5 to 10 seconds. It really comes down to, it's not the time that matters. It is the how much blanching you see. So depending on the child, depending on blood flow, it may take you 5 seconds, could take you 8 seconds, but I would say on average, it's 5 to 10. Once you finish that first stage and you see that papilla is blanched, and really that blanching only needs to be in about a 4 to 5 millimeter diameter here. Now I'm going to switch positions. I'm going to just focus here. So I'm coming in at about a 45-degree angle. I'm in line with the bone. Perfect. Okay. What I don't want you to do is, as you initially start to put a little pressure down, you see if you come off angle a little bit, your needle can bend. So I'm really making sure that that pressure is down the long axis of the unit. I'm coming in at about 45 degrees, and I'm pressure, and then pop through. So if you see, I'm at about 45 degrees here. Okay. If you are too horizontal, you got to make sure that you're not coming through papilla to papilla the other side. So if you immediately see blanching on the lingual surface here, you've actually probably not entered the bone. So 15 degrees, change position about 45 degrees. I'm slightly right in the middle of that papilla, angulation, and then through. That answer that one, Chris?
I think it did. Yeah. If you guys have any follow-up questions to that, please put them into that Q&A. But hopefully that was a good demonstration.
Here, let's say I'm working on I and J. So I've come the same angulation, right? So I'm going to turn my patient's head, and it's a little hard to do on camera. And I'm just coming in at that 15 degrees and then rotate in 45. And that's why my choice really, if I'm working on I and J, I'm going to give palatal. Now, could you rotate your patient's head all the way around? Absolutely, you could do that, right? But I just think it's a little easier to slightly rotate and come in palatally there. Okay.
So we just had a question pop up as well. Are you injecting anesthetic while pushing into the bone? So as you're going through the 3 steps,
right.
I don't know if you can zoom out a little bit more, maybe show the foot pedal.
Yeah. So am I injecting while I do that? No. It really is 3 separate stages. So it's 15 degrees, waiting for it, getting that blanching papilla, changing your angulation, and then manual bone penetration, and then stepping on the pedal. So small pedal is for that stage 1, just for the papilla. And then once you have your manual bone penetration, then you're on the big pedal. Some people have asked previously about why don't we just use the big pedal for everything? The reason being is, remember, there's a ramp up here. So if you use the big pedal for stage 1, it's going to start delivering the local anesthetic faster and faster. You don't want to over deliver here in that first stage, because if you do, you run the risk of having too much local here and having a numb lip afterwards. That's the number one reason why I found where docs are having an issue with numb lips after that first day, or actually with the injection whatsoever.
Awesome. Next question was, are you changing out the needle for each new quadrant?
I am. You know, if it's a very young patient and the kiddo's having a tough time, have I used the same needle for 2 different quadrants before? Yes. But, you know, the cost, what's the cost of the needles, Chris, about, or Jordan?
27 cents.
27 cents. You know what? I showed you that photo earlier about the tip of the needle is slightly bent after the first use. I'm just changing it out every single time. It's not worth saving. I mean, what are you going to save, like $100 for the entire year trying to reuse these guys? You have a better chance of no sensation given your patient whatsoever, and easier manual bone penetration with a new needle every single time.
And then our last question is a good one. I know you went over this, but it's definitely a good one to repeat. How long should you expect the area to be numb? I'm thinking post-extraction comfort.
Yeah, great question. So if you're using 1 to 100,000, remember it's 45 minutes to an hour. 1 to 200,000, it's 30 to 35 minutes. So if you're worried about length of having that patient numb, you may, towards the end of the appointment, even if you're using the 1 to 100,000, just go back in the same hole, give a quarter carp just to kind of top them off before they leave, And I'll routinely do that if I think it's going to be a painful procedure. Especially let's say if I'm placing zirconia crowns and I know that I'm going to irritate the tissue with my burr because I'm going subgingival. I will very often at the end of the appointment maybe just give a quarter carp. I go in the same hole just to prolong the amount of local anesthesia time that patient has.
Excellent. No further questions at this point. We'll give it a second if anybody has any last minute questions. But while we're waiting for that, just a reminder, the surveys for CEs will be sent out via email tomorrow afternoonish. So be on the lookout for those. Submit those surveys. We do value your feedback, especially Dr. Solomon. Loves getting the good feedback, even negative feedback. It's all constructive criticism. So
Please.
Once you get that survey, send that back to us, and we'll send you an email, follow-up email with your CEs.
Chris, if people want to purchase units, I think last webinar, someone texted me afterwards, who's the best contact person to purchase? All three of you? All of you?
Either one of us. Yeah, either one of us. Whoever you think is nicer.
Oh, perfect. That would be Erin then. So she's
definitely Erin. Yeah. One more question came in. Any long-term side effects to the affected bone after giving an IO?
Yeah, not that I know of or not that I've experienced. Yeah. The only time that I've had, and it hasn't happened to me, where I've had docs say my patients were a little sore, was with a teenager using 1 to 100,000 and thinking that they could give, if they gave a 3/4 or a full carp interceptally, they could numb more teeth in the quadrant. It's not going to do you any good, but just have sore papilla, sore bone.
Yep. Great question.
I have a question that came up that I don't think was answered. So I had a doctor message me and say that they had delivered a full carp and believed they were in the bone, but did not have profound numbness.
Well, number one, I don't think they need a full carpio. I've never full carp. And that comes from a few, let me just go back here quickly. So number one, it could be that, let me blur my background. It could be that they gave their injection too horizontal and they passed through the papilla. And the easy way to tell is if you have immediate blanching on the contralateral side, you're not in the bone. Okay. The other thing is that they may have been injecting into an area where there's not organized bone. So if there was an infection there and you look at the PA and there's no bone in that area, you're not going to marsupialize, you're not going to coalesce all that local anesthetic into the cancellous bone. We know that especially if a tooth, as it becomes infected, especially chronically, the body tries to wall that off. So it may just be sitting in soft tissue. They may not be into the body of the cancellous bone. And that's typically where it comes from. So you've got to check your radiographs ahead of time. You should never, just like any patient, you're not going to do a procedure without looking at a radiograph. You've got to look at your radiographs ahead of time and make sure you're in sound bone. If your goal is giving intraosseous, right? If you have an over-retained tooth and you're just going to give soft tissue, that's a whole different story.
Good. A follow-up question about the recordings in the survey. So the recording does not come with the survey, the link for that. That'll just be posted on the NuSmile website on that link under the webinars. Typically by Friday, usually get that up by Friday. The email will just have the survey. So survey will be completely separate from the recording.
Okay.
We did have another one. Let's see. What if you give on the buccal side, believe you were in bone, but no blanching on lingual side? Should you give lingual as well if they are not numb, or would you do a new injection site on buccal?
No injection site on buccal. I mean, you could give lingual, but I typically just pick from the very beginning. You want to pick where you've got healthy bone and just go with that. You can move one tooth mesial or one tooth distal. It's absolutely fine to do. Or you can go give. I mean, the way that I think about this, if you think about an orange, right? The rind of the orange is the cortical plate. And inside where the fruit is, that's where the apex of the tooth is. That's where the cancellous bone is. So it really doesn't matter where you get through that orange. As long as you get through the rind and you're into the fruit, everything that fruit touches is going to be numb, if that makes sense. So you just got to get through into the fruit of that mandible or maxilla.
Awesome. Thank you. As of right now, no further questions.
Okay.
So again, be on the lookout for the survey emails tomorrow. Get you your CEs, and recording will be posted by Friday. Hopefully we will see some of you at an upcoming workshop. They really are really good opportunities to get some hands-on exposure with these devices. Typically what ends up happening is everybody wants to start injecting on each other. So it turns into what's the dental school terminology? Stab lab. That's right. Stab lab. So really good time, really informative, but hopefully we'll see a few of you there.
I like all of you, but none of you can stab me when we get to Newburgh.
You don't want us to. But yeah, with that being said, I think we'll go ahead and call it, everybody. Really appreciate you spending your Wednesday evening with us. Hopefully everybody has a great rest of your week. Happy early 4th of July, and we will hopefully be hearing and speaking with a bunch of you soon.